As mentioned, my name is Harold Bays. Basically, I'm an endocrinologist, but a clinical trialist. That said, this presentation is going to be talking about the physiology and pathophysiology and things that, from an obesity medicine specialist, that I think cardiologists just really need to know at this point in time. With regard to specific medications that are either approved or specific medications that are in development, I'm not going to be talking about them very much. We'll leave some time at the end, but you can hear all that. Here in a few weeks, I'll be giving an hour presentation on investigational agents at the Obesity Medicine Association, and also at the American College of Cardiology. I also have a presentation on anti-obesity drugs in development. Again, what does the cardiologist need to know? So there's just so much going on right now. As further background, I've been doing this for about 35 years, and the feeling that I have right now and the enthusiasm I have right now is exactly how I felt 30 plus years ago when we were developing the statins or the ACE inhibitors or the ARBs or the calcium channel blockers. Very much a lot of science. Seemed like there was something new every single day. Just an exciting time. And then we went through, I would say, decades with regard to the obesity space, and really not much going on, but that has totally changed. And every single day it seems like we're getting offers for new clinical trials that they're wanting us to conduct on novel mechanisms of action. So just extraordinary how things have changed, not just the past 5 years, but just in the past year. So I think cardiologists need to be up to speed on what's going on. So that's what we're going to be talking about today. This is a picture of our research site. These are my disclosures. So we're going to talk about how does obesity contribute to cardiometabolic risk factors, and how does it contribute to cardiovascular disease? I think you have to start at the beginning. Number one, do calories matter? My guess is it wouldn't be too hard to find speakers who would get same sort of camera setting, same sort of virtual presentation, same sort of introduction, who will tell you that calories do not matter. And the thing that's really great about these folks is they get the best speaker ratings of anybody, because they're telling people, I think, what they want to hear. They're telling patients what they want to hear, and they're taking clinicians who are frustrated about the inability to manage the obesity epidemic, that it's nobody's fault. No blame. Certainly don't want to blame. Nobody wants that. And so calories really don't matter, and there must be something else that is going on. Well, that's not what you're going to hear from me. Okay. The fact is, folks, it's physics. Okay. Calories do matter. The first law of thermodynamics states that while energy can be transformed, it cannot be created or destroyed. So that's just basic physics. But what I would say is that that when you start talking about calories in versus calories out, there's more to it than that. There's more to it than the physics. Okay, for example, ultra-processed foods are often energy dense. So for the same amount of food, you're getting far more calories. And I think too many times people equate amount of food to the caloric density of food. And I think that's where people get tripped up. And then you have billions, if not trillions of dollars of advertisements and manners in which food is processed, so it overwhelms or overcomes the brain's natural inclination to achieve healthy caloric balance. That's what your mind, your brain was intended to do. But again, when you pump in trillions of dollars to overcome that with regard to food, the way food is processed and advertised and such, I mean, your brain doesn't have a chance, or for most people, it doesn't. The accessibility, mental stress, psychiatric disease, eating disorders, disordered sleep, immobility, information gap, obesogenic medications, inertia, just, you've heard the term set in your ways. We're going to talk about that. And then on the other side, what are things that you can do with regard to calories in? Well, you can take anti-obesity medications and reduce hunger and such, and restrict food intake with healthful nutrition. And there are some medications and microbiome and these types of things, and bariatric procedures. So a lot goes in to calories in. At the same time, a lot goes into calories out. So it has to do with your resting metabolic rate and the degree you're engaged in physical activity and thermal effect of foods. What about medications that excrete energy, like the SGLT2 inhibitors? Who knows better about SGLT2 inhibitors than cardiologists, right? Intestinal malabsorption, that is a mechanism of action of bariatric procedures. And then there's other things like uncoupling proteins and brown and beige fat and skeletal muscle efficiency and these types of things. So it is absolutely true that calories in equals calories out. But it is also absolutely true that it's beyond that. There's more to it than calories in to calories out. Here's just an example. It's not just the amount of food. It's what kind of food are you eating? So if somebody comes to me and says, Doc, I'm trying to lose some weight here. Is it okay if I still eat 4 apples a day? I'm pretty okay with that. Because maybe you'll get an additional 200 calories per day. But when you talk about the increase of satiety and the fulfillment and the fiber and the water and those types of things, you're going to be better off. But what you're never going to hear me say is, well, can I have 4 extra servings of bacon per day? Well, no. I mean, I would prefer you not do that. I don't think that's part of a good, healthful, nutritional program. So that's what I'm trying to say, is that it isn't necessarily the amount of the food, it's the caloric density of the food. Now, I know a lot of people say, well, I have so many patients in my clinic, they come in and they just don't seem to have any resting metabolic rate, not sure what's going on with them. And well, folks, that's just not true. That's a myth. All right. Most patients who have the have the obesity actually compared to their lean counterparts will have an increase in resting metabolic rate. And why is that? It's because you have extra cells in the body that need maintenance, that need energy, and that would be the fat cells. And if you are active, then if you have an increase in weight due to the increase in body fat, then you're going to have an increase in muscle. Most people who have the obesity who are physically active will have more muscle, not less muscle, than folks who are leaner. Now, don't get me wrong. There's plenty of people out there who have immobility and such, who not only have obesity, but have sarcopenia, and that's a problem. That's a huge challenge. That's a huge challenge for the primary care doc. That's a huge challenge for cardiologists. Okay, so really, really tough. But the overall message I'm trying to convey here is, don't ever get the notion that it is this decreasing resting metabolic rate that is somehow the cause of people's obesity. Okay, what about other aspects of the brain and mental stress and such that contribute to ill health? Well, we know all the types of things that mental stress can do that can affect our patients and such, as shown by this figure. But mental stress can also contribute to the obesity, as well as cardiovascular disease, as well as metabolic disease and psychiatric disease, inflammatory disease, and cancer. And this is one of many examples, and hopefully by the end of this presentation, I will have convinced you that I'm not so sure that most of the ailments that we see in our patients, the most common metabolic abnormalities we see in our patients, they're kind of all one disease. I mean, there was a time where we would silo cancer, and we would silo heart disease, we would silo diabetes, we'd silo hypertension, we'd silo lipids, silo thrombosis, and everything is their own separate disease. But given that these are many times, not all, many times all have the same contributors, in many ways, all of these have the same basic underlying pathophysiology, which, oh, by the way, should result in no surprise that many of the recommendations we make for all of these are quite similar. Healthful nutrition, routine physical activity, behavior modification. And then you add on top of it that you can get bidirectional effects of the obesity and the depression, which again, as an endocrinologist, I certainly see that with regard to the obesity and the diabetes, but you as cardiologists certainly see in your patients with cardiovascular disease. So here's, again, something provocative for you to think about, that ultra-processed foods are conceptually similar to chronic mental stress. Like, what does that even mean? Well, let's say you have chronic mental stress. That will overcome your cognitive control, will occupy your attention, divert your attention, will affect your homeostatic processes in your brain, will affect emotions, and will affect your inclination towards reward behavior. Well, ultra-processed foods do the same thing, and that's the problem. Ultra-processed foods are, again, they're designed and they're advertised to do exactly the same sorts of things, to overcome cognitive control. So you may say, I know there's certain foods that I shouldn't be eating. You know, I should just set them aside. But when you see the advertisements and then you taste how good they are and everything, that overcomes that cognitive control. It diverts your attention. It can affect the homeostatic processes of the brain. It can affect you emotionally and the reward center. I mean, don't even get me started on that. How many times you heard, here's the conclusion I've come down to. When it comes to reward centers of the brain, you know, there's two times. One is people would say, I've had a horrible day. I'm going to go out and just eat whatever I want because I've had a bad day. I deserve a reward. But I've also heard people say, I had a really great day and I didn't feel like I deserve a reward. So I'm going to go out and not care much about the healthfulness of the foods that I'm eating. So, you know, the two occasions for which people want to reward themselves and perhaps not adhere to a healthful diet would be if they have a good day or a bad day. Right? So or if they have a boring day. So that's a lot of days, folks. And that's the reason I think we need to. Sorry? Okay, I think somebody's not on mute there, but so anyway, the point I'm trying to make is that the foods that our patients are being exposed to, and the advertisement does a lot towards overcoming what should be the homeostatic way in which our bodies live in the world. So if you have natural whole foods, then the balance works great, and that's a healthful process, and we end up with healthy bodies. But with ultra-processed foods and relentless advertisements and such, that overcomes those homeostatic effects on the brain, and things become unhealthful. Okay, so let's get more specific. How does obesity contribute to cardiometabolic disease? First thing to know is cardiologists, and I'm just begging you, please look at obesity as a chronic disease as you would diabetes, hypertension, dyslipidemia. I don't think anybody should get the notion, well, if we could just get the obesity and get the weight down to a healthy body weight, then we can stop the anti-obesity drugs and the nutrition, physical activity, because it's all cured. We would never say that about diabetes, hypertension, dyslipidemia. Shouldn't say about obesity. Now, is it possible there's some people, less than 5%, that could, once they have the weight down, they can keep it off on their own without those types of things? Well, sure, everything's possible. But you could say the same thing about diabetes, hypertension, dyslipidemia for many people. Okay? But what the assumption should not be, if we could just get the weight off, we know we can keep it off, because that's not clinical reality. So what's the problem with putting on increased body fat? What's the problem? Well, as your adipocytes expand, enlarge, and your adipose tissue expands and enlarges, what happens is you get deranged endocrine and immune responses, resulting in what we call the sick fat disease or the adiposopathy, and that directly contributes to increase in blood sugar, blood pressure, dyslipidemia, and other metabolic disease. But it's doubly bad with obesity because you also get the fat mass disease, where just the increase in these pathological biomechanical physical forces puts stress on joints. So you get knee and hip arthritis. You get sleep apnea because of increase in fat around the neck tissue. You get tissue compression and such, and tissue friction and such. So you've got these two issues, and sometimes they're not so easily separated as far as from a pathophysiological standpoint. But the point is, obesity does have both of these things that are adversely affecting our patients. Now, I want to make this very, very, very clear. Not every case of diabetes, hypertension, and dyslipidemia is due to the obesity. And we have got, as people engaged in cardiometabolic prevention, cardiovascular disease prevention, preventive cardiologists, preventive cardiology, please let us all remember this, and not just remember it for scientific presentations or for clinical presentations, but remember it when we see patients. Because few things are more frustrating than if a patient goes in to see a clinician about something, whether it be diabetes, hypertension, or dyslipidemia, or any other kind of ailment. The first reaction is, well, if you just lose weight, then, these things would all get better. Our patients with the obesity are deserving of knowing exactly what's going on as the underlying cause of their disease as anybody else. And it should never be just assumed that it is the obesity that is the causal factor with regard to diabetes, hypertension, dyslipidemia. So that's as much as I'm going to talk about the causality, please remember, there are a lot of other ways that patients can have these metabolic diseases. Okay, let's talk about adipocytes. Just brief overview. I mean, obviously, if you wanted to explore this in detail, you can either read articles that I've written and other people have written, or you could have like a month-long symposia, daily symposium. I mean, there's a lot going on because your adipocytes, your adipose tissue, very active endocrine and immune organ. And here are just some of the immunopathies and the endocrinopathies and the lipotoxicities that you see when you get enlargement of the adipocytes and expansion of the adipose tissue. So what on earth is adiposopathy? Well, folks, it's not any different than what we do for other diseases, such as cardiomyopathy, myopathy, encephalopathy, ophthalmopathy, retinopathy, enteropathy, nephropathy, neuropathy, and dermopathy. I mean, the idea that the organ that takes up, for many people, the largest percent of their body weight can't be diseased is just, I mean, that's just, I don't think that's very scientific, okay? For some people, it constitutes over 50% of their body weight and everything. The idea that somehow that can't be diseased is just, not very insightful, okay? Not very insightful. And if you think about it, particularly from a cardiology standpoint, you say, what's cardiomyopathy? Well, you get an increase in heart cells, the heart becomes dysfunctional, and you get heart disease. Well, it's the same thing with body fat. Your adipocytes become enlarged, adipose tissue expands, becomes dysfunctional, you get disease. Let's talk specifically about diabetes. Again, same sort of underlying principles. Immunopathies, endocrinopathies, increased free fatty acids. You develop insulin resistance, beta cell dysfunction. If you want to get a little bit more granular, when you get adipocyte hypertrophy, increase in adipose tissue accumulation, you end up with adipocyte and adipose tissue hypoxia, okay, relative hypoxia, sometimes not just with dysfunction, but with adipocyte death. You also get increased delivery of free fatty acids to organs such as the liver and muscle, and you end up with lipotoxicity with an intracellular ceramide accumulation, so that's lipotoxicity. Maladaptive mechanical transduction. What on earth is that? Well, if your adipose tissue is going to expand, it's got to dissolve that extracellular matrix to allow for it to expand, and then it's got to be reassembled. And if that is disrupted, then you can't expand your adipose tissue. So what's going to happen to your energy? What's going to happen to that excess energy if it cannot be stored in your subcutaneous adipose tissue? Well, it's going to go to your visceral, okay, your visceral fat depots. And what visceral fat depot could have very high relevance to you folks? Well, how about the epicardial fat, right? Epicardial fat is the visceral fat of the heart. And there's a high correlation between visceral fat of your organs and visceral fat of your abdominal organs and the visceral fat or the epicardial fat of the heart. And then, of course, there's the intraorganelle dysfunction, mitochondrial dysfunction, dysfunction of the endoplasmic reticulum. And you get the release of all these adiposopathic factors, as I said, derangements of hormones, derangements of immune responses, and then release of these extracellular vesicles and such. So there, in a nutshell, is how it is that obesity contributes to the diabetes. And just again, just because I've been down this road, just to be clear, there's an expression, he who only has a hammer thinks everything looks like a nail, okay? And so I want to make sure that's not the point I'm trying to get across. Because whatever dysfunction you have of your adipocytes and your adipose tissue, whether you manifest that as clinical disease, very much depends on how all of that interacts with other body organs, whether it be the liver, the muscle, the pancreas, the brain, other body tissues. It is through that filter, it's through that interaction that you ultimately end up with potential clinical disease. And that's where people get confused, because they will point out, well, there's some people out there that really don't, maybe modestly overweight, and they still end up with the diabetes mellitus and such. Absolutely. And for many of those folks, they got inherent limitations or inherent enzymatic problems with their liver or their muscle or whatever. So I'm not saying it's always due to the increase in body fat. I'm just saying that that interrelationship exists. And if you had to pick something that you can do something about, like you've heard of Occam's razor, right? Sometimes the simplest solutions are the best. Then I think you got to go with the obesity, because what are you going to do? Unless you're going to implement gene therapy, I mean, what are you going to do if there's a limitation of the liver, limitation of the muscle, limitation of the pancreas and such, right? So go to the place that's the simplest to correct. All right, so this is a pop quiz. I'm going to ask you a quiz to see if you've gotten these concepts. All right, so you have positive caloric balance. You get proliferation and differentiation of functional adipocytes. And if they are truly functional and they're working like they should, then even though you'll have an increase in body fat, maybe you mitigate the onset of metabolic disease. But on the other side, what if you have limitations in your ability to proliferate and differentiate functional adipocytes? What if you have limitations in the expansion of your adipose tissue? Well, there you have an increase in body fat, but now you have the metabolic disease. So here's just a quote. Dr. Alan Shape, many of you know him. Strategies to increase the recruitment of adipocyte progenitor cells to expand adipose tissue by increasing adipocyte cell number could be protective against the metabolic consequences of obesity. So with that said, is anybody aware of a drug that we use to treat the diabetes, and some people lipids and such, that as part of its mechanism of action is treating, again, diabetes, dyslipidemia? Many people associate that with as the result of an increase in body fat. Is anybody aware of a class of agents that we use where the mechanism of action is to increase the proliferation and differentiation of functional adipocytes to treat a disease that folks like me believe is due to an increase in body fat? Well, we probably have people muted, and many of you probably know, but it would be the thiazolidinediones, right? The PPAR gamma agonists. And how do they work? They increase, yes, there is some fluid increase, and that's true, but they increase the proliferation and differentiation of functional adipocytes. And that's why when you put people on the thiazolidinediones, you put them on the pioglitazone or the rosiglitazone, what happens to their body weight? Goes up. Okay, it goes up. Why? Because yes, again, maybe some fluid, but it goes up because you're increasing the amount of energy that is now stored that's available to be stored inside these increased number of adipocytes and such. What about the converse? What is the best way to predict whether nutritional intervention, or whether it be a structured program, or whether it be bariatric surgery? What's the best way to predict if it's going to cause diabetes to go into remission? The best way to predict is the degree of success in weight reduction. That's the most consistent factor across all of these different types of interventions, is the reduction in the body fat. Why? Because as you reduce adipocyte size and you reduce adipose tissue accumulation, you're increasing the functionality, all right? And therefore, you're going to see improvement in such things as blood sugar, but I would also say blood pressure, dyslipidemia. What about blood pressure? Well, I'm not going to go into it in too much detail, but I think you're familiar, is, clearly a lot of these processed foods don't just have, they don't just have increase in fats and such and energy density, they have a lot of sodium, right? Physical inactivity. You can see all these, kind of mechanisms, whether it be adiposopathic vascular abnormalities or heart abnormalities or increase in insulin secretion, sleep apnea, psychosocial stress, increase in mineralocorticoids, all of these types of things. That's what happens when you have the obesity. It increases, it is a causal, it is a contributor to the increase in blood pressure. What about dyslipidemia? Same sort of thing. I think we're familiar with this. If you have this adiposopathy, you have the inability to properly store these free fatty acids that go into your liver, then they're going to be making all these what? Very low, they're going to be incorporated within these very low density lipoprotein particles. And once those get secreted and such, you start having all these enzymatic exchanges, mainly through what we call cholesterol-ill ester transfer protein, CETP, for which there are drugs in development, CETP inhibitors, and we've been working on those for decades, it seems. But you end up with that typical adiposopathic dyslipidemia, sometimes called atherogenic dyslipidemia, where you have increase in triglycerides. So that's because you have an increase in VLDL particles, increase in triglyceride-rich lipoproteins and remnants, decrease in HDL cholesterol, reduced ApoA1, increase in non-HDL cholesterol, ApoB, LDL particle concentration, although maybe not LDL cholesterol. And if you want to know more about that, it's in preprint right now. There's a joint statement put out by the Obesity Meta Association, National Lipid Association on obesity and dyslipidemia. It's a very mechanistic-based discussion, but I think it also has a lot of really great clinical stuff in it. We're at the galley proofs right now, but the preprints are out. And then finally, increase of the small dense LDL particles. So again, here's mechanistically how you have the obesity that's contributing to these major cardiovascular disease risk factors. I hate this term. Sometimes you hear this term, comorbidities. Hate that term. Comorbidities makes it sound like they just accidentally, serendipitously just happen to come together. I don't look at it that way at all. I look at it as for many people, not everybody, but for many people, the type 2 diabetes mellitus, the hypertension, dyslipidemia, the increased risk of thrombosis, these are the complications of the disease of obesity. Thrombosis, not going to go into detail, but I think you know this. You get compression from the obesity that contributes to venous stasis or sleep apnea or inflammation or hypercoagulability or hypoxia, endothelial dysfunction, hyperinsulinemia, hypertension, dyslipidemia, and unhealthful nutrition and physical inactivity. All of these contribute mechanistically to thrombosis. So again, all of these are interconnected. So how does obesity contribute to cardiac disease, which is why we're having the call? Well, first of all, on the right side, you see here, there are indirect effects like generation of cardiovascular disease risk factors. And that's the reason I spent some time on that, because that's what we're mainly focused upon at this stage, okay, this stage in medical science and in clinical medicine. But what about the direct effects? I think, as many of you know, and I wish you would get the word out to your colleagues, to your internal medicine colleagues and such. What about the epicardial adipose tissue, which again is simply the visceral fat of the heart? Well, let's just start, the very most basics. Fat mass disease can contribute to cardiac dysfunction. Mainly the HFpEF, the heart failure with preserved ejection fraction. We used to call that diastolic heart failure, but there is some mechanical constraints that occur when you have increase in epicardial fat. You're contributing to sleep apnea. That's a fat mass disease. And I think all of you know the degree by which sleep apnea can contribute to cardiovascular disease. And then we just talked about how obesity with regard to fat mass disease can contribute to thromboembolic events. But what about that epicardial fat accumulation? It isn't just a mechanical problem. There are pathogenic paracrine and vasocrine signaling that occurs with sick fat disease, with the adiposopathy. You have increase in inflammatory macrophages and T lymphocytes and adipokines, all these types of things. And all of those contribute to heart failure, atherosclerotic cardiovascular disease, cardiac dysrhythmia, fatty infiltration of the heart and such. So, so again, yes, it is fat mass disease, and that is true. But that epicardial fat can be metabolically and immunologically active, and not in a good way, okay, in a pathogenic way.
A conference on the 3rd floor that a bunch of people will be coming in for. Sonia, who's my admin, she said she would kind of try and be down here and let people in.
Okay, somebody want to talk to whoever that is? You probably know who that is. Okay.
Yes, more about that. Thanks.
Okay, thanks. All right. So what about others? Well, obviously, obesity contributes to kidney disease, and I don't have near enough time to talk about that relationship with heart. What about fatty liver? I mean, I think cardiologists, if you think you need to know about the diabetes, hypertension, dyslipidemia, and thrombosis and such, and obesity, I think the MASH people are going to tell you, you really need to know about that too. Polycystic ovarian syndrome, gout, all of these things. And then there's cancer. Obesity is the second most common preventable cause of cancer and such, behind cigarette smoking. And a lot of people believe the increase in body weight is contributing to increasing rates of cancer among young adults. And here we go again, this concept that all of this is sort of one disease. The obesity, the mental stress, cigarette smoking increases things like reactive oxygen species with endothelial damage, DNA damage, cancer, fibrosis, aging, all of those things. So again, this idea that we can just silo people out, I think you as cardiologists have determined that's just not going to work anymore a long time ago, particularly with the advent of the SGLT2 inhibitors, but I would also say the GLP-1 receptor agonist as well. And then here's just some specific mechanisms how obesity promotes cancer. It would be adiposopathic cytokine production, hypoxia, oxidative stress, tumor microenvironment alterations, cancer-producing hormones, unhealthful nutrition, and so forth. Now, here's what I think is, some people everybody always want to look at the negative. Okay, I like to be positive. I look at the positive. So here you have the 1960s. Cigarette smoking, 42% of folks were smoking at that time. Why? Because that's what you did. Every movie had people in there, all the cool people in Hollywood, they were all smoking. Everybody was smoking. And then there were only 13% with obesity. And then you look at 2018, only 15% of people are smoking in the US. If you go over to what? Asia and Europe, it's like 20+%, okay, are smokers. So I want you to look at that. But look what's happened to the obesity. It's flipped. Like now, over 40%. Okay, over 40% have the obesity. So what is the lesson? What you could say is, oh my gosh, obesity only 13% to 42%. We're never going to conquer this. Can't be done. Nothing can be done about it. The ultra processing food industry is too powerful. Advertisements too powerful. Too many forces out there. Can't possibly do it. You don't think in the 1960s that big tobacco didn't have power? I think you need to revisit history, because they had all the power and all the messaging that was out. I mean, there were people telling people cigarette smoking was a healthy thing to do, right? A healthful thing to do. But yet through all sorts of education and public initiatives, and societal changes and these types of things, look what we've been able to achieve. I think that's worthy of congratulations. And I think if we could ever get our leaders to get it together and come up with a rational global plan, I'm optimistic we could do the exact same thing to obesity. So here is the relationship between sleep apnea and cardiometabolic disease. I just put this in because that is just so important. And I'm sure you all see that every day. I'm not going to go through like what these definitions are, how it's defined. But other than to say that clearly there's adverse cardiometabolic consequences to untreated obstructive sleep apnea, worsening obesity, congestive cardiomyopathy, atrial fibrillation, stroke, diabetes, hypertension, these types of things. So Clearly, that's important from a fat mass disease. All right. So how do we assess obesity? So now hopefully I've made the case, at least someone made the case, that obesity is important from a cardiology standpoint. It's important from a fat mass disease standpoint. It's important from generating major cardiovascular disease risk factors. It has direct adverse effects upon the heart. But how do you diagnose it? I mean, you think that's something we should have figured out by now. Unfortunately, we're still using body mass index, which in most cases, in fairness, is pretty good measurement. Not all the time. We do a lot of DEXAs here. People, they find us. We don't advertise, but people come in here requesting that we do dual X-ray absorptiometry that looks at your percent body fat, your amount of visceral fat, your amount of android fat, your amount of lean body mass. And this becomes really, really important. You hear people talk about, we really are interested in diversity. We're really interested in, things that affect people based upon race and sex and these types of things. But some of that gets lost when it comes down to the most basic diagnoses. So here we're talking about cardiometabolic manifestation of obesity in Black individuals. And yes, I get it. We wrote this paper. You'll see, some of the people co-authors are of the belief that race is 99% a social construct and maybe 1% less genetic. Okay, but it's mainly a social contract. I don't think that's where I am. I understand the point, and I think that's probably the major issue. But I do think there are genetic variances. If you look at people strictly from Africa, not African Americans, strictly from Africa, there are some genetic tendencies towards hypertension, kidney disease. There's certainly, I think, genetic predispositions towards certain types of biomarkers and such, and higher rates of insulin resistance. I don't think all of those are just social constructs, but applicable to what we talk about today, Black individuals often have decrease in visceral fat and increase in muscle mass. Not always. This idea that you can just take a brush and say every person, every person that comes in that says, okay, I'm a Black individual, that must mean I have an increase in muscle mass. That's just not true. It's not true. So how can we know if it's true or not true? How can we know if an individual based who have variances with regard to race, what their visceral fat? You have to measure it. You have to measure it. And let's just take, forget whites and Blacks. What about Asians? What about people from Asia? Asian folks? Well, what happens there typically, I think you already know this, is they tend to have maybe a body mass index that isn't outside the range of normal, say, that you would have for U.S. population, non-Asian U.S. population. But they'll have an increase in visceral adiposity because they have enlarged adipocytes. They have limited ability to proliferate and differentiate in the subcutaneous adipose tissue. So that's the reason you hear that's one of the reasons you hear so much about increased risk of folks from where? South Asia, right? We did a whole roundtable discussion in our journal on the increased risk of cardiovascular disease among folks from South Asia. But guess what? Some of that applies, at least with regard to diabetes, in people from East Asia, which is just remarkable to me that nobody ever seems to want to talk about people from East Asia. That's like 1/5 of the planet, folks. And I get it. The people in South Asia got a specific type of genotype, phenotype, these types of things, high cardiometabolic risk, and I get that. But I think we ought to have been spending a lot more attention than we do on folks from East Asia, because it's not like they don't have heart disease. And again, we did a roundtable discussion on that as well. And what about sex? We hear a lot about male versus female and these types of things. Well, it's certainly true that increased risk of hypertension in females greater than 60 years of age. That's true. Higher risk of coronary artery disease, higher risk of complications once a female has cardiovascular disease. Definitely differences in certainly premenopausally in the lipid profile, increase in non-traditional risk factors, differentiate or perhaps different symptoms maybe different pathological pathogenic pathological manifestations, whether it be microvascular or macrovascular disease and such. Higher risk of higher risk of death due to cardiovascular disease in females with the diabetes and such. But focused here, often with a decrease in visceral fat and decrease in muscle mass compared to males. And it is just remarkable. I read our DEXA reports every day. And it's just remarkable how many times we see females that come in and they have their percent body fat above 40%, and yet their visceral fat is like less than 1 pound. I mean, it's just stunning, the differences. So whether it be race or whether it be sex, big differences. Okay, big differences. And so for many of our patients, just simply looking at a body mass index is not the optimal way to be assessing our patients. So the next question is, when is obesity best treated? Well, again, I would look at this the same way that you would look at diabetes, hypertension, dyslipidemia, and thrombosis for that matter. The earlier the intervention and the longer the intervention, the better outcomes that you're going to get. And that starts like right from the beginning. You have a patient, they don't have diabetes, hypertension, dyslipidemia. They put on 10 pounds 6 months later. Now they got all three. If it's not acute, if the elevations in the blood sugars are not astronomically high, or if the lipids, if the triglycerides are not in the thousands, and if the blood pressure is not exceedingly high and such, then I think we've reached the point now with the advent of the GLP-1 receptor agonist and others that are coming down the pike and such, that it's time to go back the way we used to do things in primary care, right? I did primary care for years when I had an endocrinology practice. I didn't just do endocrinology. And if a person came in and they had mild hyperglycemia, mild increase in blood pressure, mild dyslipidemia, whatever, and you could just see that it was temporally related to increase in body fat, we would engage the patient, actively engage the patient in nutrition, physical activity, and see what we could do. We treat the underlying cause first. Well, now I think we even have greater opportunities. So if you have a patient with the obesity and diabetes, I think it's perfectly fine to say, let's focus on that obesity and let's put them on a GLP-1 receptor agonist, because we know that it's going to have robust reductions in body weight, depending upon which one you choose. You know that it's going to improve the blood sugars, because at the lower doses, they're approved as they're approved as anti-diabetes drugs. And now with the results of the SELECT trial with the semaglutide, we know that in patients at higher risk and such for cardiovascular disease, who have an increase in body mass index, that it improves cardiovascular disease outcomes. So we know this now. We didn't know this a year ago. So to me, I think this is the new paradigm. The new paradigm is put this patient on an effective therapy that's going to address the obesity and improve these cardiometabolic risk factors. And let's start there and let's see what happens. And you say, well, isn't that kind of what we're already doing? No. If we have a person that has acute or is newly diagnosed with diabetes, many times the clinician's first inclination is to put them on a what? Sulfonylurea. A sulfonylurea. Why? Well, because it's on the formulary, it's dirt cheap, and it gets the blood sugars down. But is that in the best interest for patients? I don't think so. As an endocrinologist, I mean, yes, I have had some patients on sulfonylureas, but it's not by choice. The idea is to the extent we can get sulfonylureas off, away, gone. And because what happens when you put people on sulfonylureas? They increase body weight. And what is the evidence that it improves cardiovascular disease outcomes? None. So hopefully in this brief presentation, you've got at least an endocrinology and obesity medicine specialist perspective on how it is that obesity contributes to these major cardiovascular disease risk factors, and how it is that an increase in body fat doesn't just contribute indirectly to cardiovascular disease, but when you start talking about the epicardial fat, you're talking about directly contributes to cardiovascular disease. And given that cardiologists, again, have already gone over that bridge, already have experience of saying, okay, maybe SGLT2 inhibitors was not something that I thought is something I would be using as much as I am, because it's a diabetes drug, and maybe that's not been my focus or whatever, but you're using it now. You crossed that bridge. You said, if it's in best interest of my patients, I need to become aware of how to use these drugs, and I need to embrace them. And I think the same thing is where we're headed with these anti-obesity drug treatments. I think cardiologists are going to be on the cutting edge of who it is that's going to be, really utilizing these drugs, not just towards improving cardiovascular disease risk factors, but in reducing cardiovascular disease risk. And with that, I'll conclude the presentation and open up for questions.